Hello, everybody. I hope that you're doing well wherever you are. Thank you so much for joining us for our discussion today, right here on South Sudanese Women Intellectuals Forum. If you're joining us for the very first time today, perhaps you stumbled upon this video by chance, I'd like to say a big welcome to you and encourage you to go ahead to YouTube, subscribe to our YouTube channel, enable your notifications, and then you will get updates every time we upload new videos. We are always uploading new videos every Saturday at 4 p.m. East Africa time because that is when we have our weekly discussions. Our weekly discussions are on various topics that affect us as South Sudanese all over the globe. And today's discussion is on disabilities and South Sudanese women's experiences. My name is Dr. Grace Joan Soma, and I'll be the moderator for today's discussion. Joining us for today's discussion is an excellent team of people who have disabilities and those who work with people with disabilities. So I am now going to introduce our panel members and read their bios, and then I'll briefly introduce the topic of today, and thereafter we can get straight into the questions for today's discussion. So today joining us, we have, I'll start with Ms. Maya Nyadaklam. Ms. Maya Nyadaklam is a peace and conflict practitioner with an interest in peace building, women empowerment, and youth engagement. She is active in the civil space with a keen focus on peace and development, inclusion, and promotion of human rights. Currently, she volunteers with Special Olympics South Sudan, which works with persons with intellectual disabilities, and she also works as a communication manager at I Am Peace. Maya, you're welcome.
Thank you, Grace.
Yeah. Next, we also have one of our panelists, Ms. Zakia Musa, who is a graduate of the University of Juba College of Arts and Humanity, Department of Psychology. She's a teacher by profession and a disability rights activist. She is a woman who is living with a visual impairment and was supposed to be here, sorry for that. Unfortunately, she could not make it to join us for our discussion today, but we hope that she would have been here with us to share her experiences on living with a visual disability. Our third panelist is Mrs. Margaret Kenyi, who is a special education specialist and the founder and executive director of Step by Step Learning Center in Tanzania. She is a South Sudanese, having been married to the late Dr. Christopher Kenyi, and has worked extensively in South Sudan with Save the Children UK as an education project manager in Bahr el Ghazal and Upper Nile for the period of 1994 to 1996. And while she was there, she was conducting emergency teacher trainings. She has extensive background in education, and this includes a master's in chemistry. She has taught biology and maths in Kenya and Uganda, and she's also taught at higher level education institutions like Daystar University in Kenya. However, she further decided to pursue more qualifications and certification in special education, and this led her to teach in a special school in Botswana. And finally, in 2005, she founded and became the executive director of Step by Step Learning Center, which is a school for children with learning challenges in Tanzania. Thank you, Mrs. Margaret, and you're welcome to the show.
Thank you.
Our other panelist, who unfortunately also is unable to join us today, is Ms. Diana Wani, who is a student undertaking developmental studies and is a disability rights activist based in Juba. We also have Ms. Tokriel Maniel, who is a licensed master social worker. She holds a bachelor's degree in social work and a minor in sociology from Winona University in Minnesota. She received a master's degree in social work from Texas A&M Commerce in Texas, and her experiences span over 12 years on aspects to do with chemical dependence and mental health. Currently, she works at a county psychiatric hospital as a behavioral health specialist. She spends her time as a volunteer with local communities, homeless shelters, and nonprofit organizations. You're welcome, Ms. Tokriel. Next, we also have Dr. Lydia Jobikson Duku, who is a pediatric cardiologist at a network of children's hospitals and clinics in the Midwest region of the United States. As a pediatric audiologist, she assesses, diagnoses, and manages hearing loss. She serves a patient population that ranges from birth to 21 years of age. Dr. Lydia was born in Juba, South Sudan, and lived in Kenya and Uganda before migrating with her family to Dallas, Texas. Despite the challenges they faced, starting life from scratch in America, her parents instilled in her the value of education, but more importantly, the principle of selflessness. This was her motivation for selecting a profession that allows her to exercise compassion by working at an organization that emphasizes quality healthcare for all populations, including underserved and most vulnerable members of society. So welcome once again to our panelists. I'd like to ask, as we go along, please have your microphones on mute. And then when I direct a question to you, then you can be able to unmute yourself and answer the question. So I'll give a brief introduction on disability, and then we will go straight into the questions. I'd like to say that for the purposes of today's discussion, we are defining persons with disability as those with long-term physical, mental, intellectual, or sensory impairments, which in interaction with various barriers may hinder their full and equal participation in society on an equal basis with others. From the outset, I'd like to say that even as we use this term disability, we are in no way trying to exclude or stigmatize individuals with the challenges or impairments that I have described above. It's just that disability is a broad and general term that is more commonly used and familiar to people in our context. And so please understand us when you find that this term has been used interchangeably with the other terms like impairment or challenges today. The conflict in South Sudan, poverty and poor access to services have increased the rate of disability and caused people with disabilities to become marginalized and excluded. People with disability in South Sudan face many challenges, which I will briefly highlight. First of all, there is a lack of data on disability in South Sudan, and this has made lobbying for issues and challenges of people faced with disability very difficult. There are actually no specific laws relating to the rights of persons with disabilities. Disability is often stigmatized. Adults and children with disabilities are also at high risk of various forms of violence and abuse. And you will find that children with disabilities face many barriers to access mainstream education, health, and other specialized services. Another reality is that most people with disabilities are unemployed and they experience financial and food insecurity. And in conflict situations, people with disabilities face greater risks of being caught in fighting and have been left behind when communities have fled attacks. Although there are disability people's organizations, they face many challenges due to political, socioeconomic marginalization of their people and lack of government support and lack of income to keep their programs running. What I have highlighted are just some of the issues facing people with disability and the disability movement in South Sudan. And in fact, today you will realize that we have experienced one of those challenges that is faced with people with disability. We have our two panelists who are individuals who are living with challenges, visual and physical challenges, and unfortunately, they have not been able to join us for today's discussion. We hope that in the future, when we organize another discussion on this very topic, we can be able to have them on board. So we shall be hearing today from those who work with people with disability and those who have perhaps children or relatives that experience any form of challenge, and they have first-hand accounts and first-hand experiences of caring for these individuals. We hope that this discussion will give us all perspective into disability and that it shall be the start of conversations and actionable steps towards improving life for South Sudanese with disability in South Sudan and beyond. So I will now go ahead straight to the questions, and I'm going to start with Mrs. Margaret Kenny. Please, I would like you to unmute yourself. Mrs. Margaret Kenny, welcome to our discussion today, and I'd like you to share with us your personal experiences of caring for someone with a learning challenge. And in this case, you have a child who has a learning challenges. Please share with us your experiences of how this has been, how and when this learning challenge was diagnosed, if there was any particular cause when you came to the personal realization of this. And you also have done a lot of work with children who have learning challenges and people with disability. Please also share with us your experiences on that. You're welcome, Mrs. Margaret.
Thank you. Thank you very much, Grace. And I must say that I'm really privileged to be welcomed as a South Sudanese by marriage only. Thank you. As you mentioned, my personal experience is a very painful one because it happened that it's our very first child, Ruth, whom we were really looking forward to having as we were late starters, who looked like she was okay, but I could see that there was something fundamentally wrong. And right now she's 36 years old. She's challenged with autism, and it's one of the most complicated and very difficult challenges that anybody can face. Besides Ruth, I will later tell you how I had to start a school around her. But through that school, more than 45 children with various challenges, which I think Grace will also want us to talk about later. More than 45. And at the moment, we have 20 on campus, but then we have outreach students, another 5 that we have to go to their homes to offer them whatever we can. And you want me to talk about really how it felt? It was devastating.
Yes.
Because by 18 months, I realized that Ruth, her speech was not coming. Although physically she's just a lovely, beautiful, strong girl, but mentally she was not really picking up. Her speech was not coming up. And so I went to a pediatrician, and she said, oh, there might be some hearing challenges, but with children, you never know. Don't worry about it. She will be all right. But I wasn't convinced that it was just hearing because, if I talked to her, she could respond. Hearing is very easy to test. Make a noise behind somebody and they will turn their head. And Ruth could do that. So I really got worried, and I knew that it was, I think, more than that. And with that came not just worry. I was very devastated. I was heartbroken, as many mothers will tell you. And then, of course, as women, tears were all over the place. There, for a long time, I couldn't talk about her without crying. And then, of course, as usual, you start self-pitying, why me? Why, Lord, how could you allow this to happen to my child? So then again, to add to her difficulties, when she was about 2 years, she also had acute respiratory problem. And she was in ICU for 4 days. And that added really to her challenges. And after that, I could realize that she had got even worse. And I think that lack of oxygen must have affected the brain even further. And so there was my journey as a young mother, worrying, crying, asking why. But at some stage, especially when we came to Tanzania, I realized that asking why was actually making my situation worse and doing nothing for Ruth. So I started changing the question to why not? And what can I do? And then, of course, I am a very keen Christian. I started fighting with God. Say, well, God, if why not me, then what can I do? What do you want me to do? And I think that that was my turning point when I started asking, why not me? What can I do? And another thing that helped me to really stop self-pitying, pity-partying, when we came to Tanzania, the only school that was available was a government school, a very, very crowded government school. And as an afterthought, they gave them a little store for children who are having challenges. And when I came, I was very keen I had already done a lot of work with Ruth when we were in England and also when we were in Kenya. And she had already made a lot of progress. But when we came to Tanzania, there was this little store with no windows, with a big stove, which was for making porridge for them, and a big desk, those desks us who are in our 60s sat on. It's what these children were having, no ball, no play. And I just cried and cried and cried. And that was my turning point. I determined that if I was to continue Ruth's progress, I really needed to start something myself. But then that was the problem. Yeah, so
Yeah.
those were my turning points, being desperate to find something for her and not finding it. So
Okay.
I just,
So,
yeah.
yeah, how do you identify the children who have learning challenges in your center?
At the center, now I've run it for 15 years. I can almost tell a new child what their challenge is. But if I am not sure, I usually just allow them to be comfortable with the other children, go to the teachers, an appropriate class maybe for their level, and we observe that child for 2 weeks. After 2 weeks, we usually come to consensus. But if we are in doubt, we have a private hospital in town with good pediatricians. There's one particular good Black American who's a very good pediatrician, and he has usually confirmed what we already suspect a child could be having. And many of them, like Down syndrome, are almost obvious. You can tell. Cerebral palsy, you can just tell. Autism is a bit tricky, but we also have two main things, like lack of speech, if they can't communicate. Another one is they can't socialize. You tell them to go to the class with others, and they're clinging to the mother and crying and not saying anything. So we do that ourselves, and we have quite a bit of experience now, but we use the hospital in town and the professionals in town to confirm our diagnosis.
Okay. So I'm just curious, how do these children actually come to you? Do you go to the community to identify them? Are they brought by the parents? And you've talked about children with learning challenges, those who are on the spectrum. Do you also work with those who perhaps have visual impairments or hearing impairments or physical challenges?
Yes, the only ones we don't have are visually impaired, although lately we had a girl who is having albinism. She's a teenager and was about to be sold off to a marriage because the parents didn't know what to do with her. She dropped out of school almost with zero. And when they brought her to me as mentally challenged, I actually discovered that she actually couldn't see because she had been exposed in the sun in southern Tanzania. They were not doing no protection whatsoever, no sunblock, no protective clothing. She had no hat. And in order for her to expose her already very sensitive eyes, you doctors know what the albinism does to the eyes. She was having to look up to avoid direct looking into the light. So she looked like she was blind because she would look upwards and not look at you at all. And if she tried to look, so actually this girl was forced through primary school, all 7 years, not able to see, and And then, of course, that's why she was, labeled as stupid and, the last one in class. But it was her albinism. And by the way, albinism in itself is not a mental challenge at all. If they are taken care of, they actually can do very well. So this is the first visual, not even impaired, because this girl, once now, we first of all treated her well because she had wounds all over the mouth and face. We gave her sunblock, we gave her protective clothes, we gave her a hat, and we gave her sunglasses. And she was perfect. I mean, now she's in the adult class. She's doing jewelry, beautiful jewelry she can see. So that was the only visual case I had. But the rest, hearing impaired, I also once had a child when I just started the program who was actually deaf. But because nobody bothered to measure her hearing, he was a young man, a young child, a young boy. He was taken as stupid and, can't amount to anything, despite the fact that this child, the parents were actually very, very learned people. But one of the issues we will talk about is lack of, resources or equipment. So nobody bothered to detect. So those were the two usually common things that we have been brought to us as mental challenges, but we quickly can see that they're not.
Okay, thank you so much, Mrs. Margaret, for sharing your story. We have a question from the audience, which I just want you to think about, and you can answer it at a later point. The question is, how do we overcome the stress of caring for our loved ones with disability? So I'm not going to have you answer the question right now. Just give you time to think about it. And in the next set of questions, you can perhaps respond to it. Next, we're going to go to Ms. Maya. Ms. Maya, please unmute yourself. Ms. Maya, you work in South Sudan, Juba, and we're hoping that you can give us perspectives of working with people with special needs groups. Please tell us where you work, what you do, and what your experiences have been working with special needs groups. If you have any personal experiences of someone close to you who has a challenge or an impairment, you can go ahead and tell us. And anything else you may want to add that will really enrich our discussion today. You're welcome, Maya.
Thank you. Hello, everybody. Thank you, Dr. Grace. My name is Nyadak Lam. I work for Special Olympics South Sudan, which is a national organization that works with persons with intellectual disabilities. The program is specifically for people with intellectual disabilities, but also we get to interact with other organizations and CBOs that work with people with disability in general. Special Olympics South Sudan was born in late 2018 out of Special Olympics International, which is based in Washington, D.C. And I officially joined Special Olympics in February of 2019. For me, the beginning was that I really had an interest in going into learning about people with disabilities, because that is something I have not done before, nor did I have the privilege of doing before. So I started out with the earlier stages of my volunteering. For Special Olympics program, how it works is that at the end of the day, you're all volunteers, but there might be, different levels, because they want to really emphasize the aspect of volunteerism. So I started then, and it's been about over a year. And over time, I have definitely learned a lot of things. Special Olympics, to be specific, does sports. So it's an organization that uses the joy of sports to engage people with intellectual disabilities. And I guess people oftentimes mix Paralympics and Special Olympics. Paralympics is for people with physical disabilities, and then Special Olympics for people with intellectual disability. And then also within the Olympic family, there's the National Olympic, which kind of caters for what we would call everybody else. So it has been a really good journey for me so far. I'd like to also touch on what Dr. Gray said earlier. For us, data is definitely a problem because that is something we don't have in the country. We've checked with the Ministry of Gender, we've checked with the committees at Parliament. There really isn't that much information and that much laws in regards to people with disability and specifically people with intellectual disability. So it is presumed that there's at least 200,000 people in the country, at least 2% of the total population. But for now, we still don't have adequate data. As for personal experience, I've not really had anybody directly in my family or close relatives, but I feel like our athletes who I'm very close to and we work very, personally and we follow their lives because our program entails every aspect, their health, the sports, their extracurricular activities. I have learned out of working with them over the past year or so. So it has definitely been quite difficult again because advocacy and awareness is very low in the country. And also there's a lot of concentration within Juba. So also within the states, we don't know what's going on over there. And then also the political situation where, governments are, dissolved and restarted and the transition now, we're in the transitional government of national unity. We're hoping that also now they can soon also complete the formation of the states so that also we can be able to reach out to state governments and state institutions.
Yeah. Okay. So I'm curious to know what type of sports do you engage the individuals that you work with? Just give us examples.
Okay, so within Special Olympics, all different kind of sports are available: football, basketball, volleyball. But as for now, Special Olympics works in athletics. That's the one we've done the longest since we began. And then we are still introducing basketball, which we'll be doing in collaboration with the South Sudan Basketball Federation. Within these sports, we have the program for the athletes with disability, but we also have what we call unified sports, which means that the athletes with disability should be able to interact with people without disability. So that also encourages a culture where they're able to get together and play together, and not only just play together, but they can also compete together. So it also provides, a competition aspect of it for the athletes as well.
Okay. So how do these individuals come to you? And what pointers can you give to parents or families who perhaps may not know that such a program exists, especially in Juba?
Yeah, so we work closely. We have a very close partnership with Usretuna, which is a very well-known center here in Juba. They care for persons with disabilities, so across different disabilities. They have different services, but specifically for that, they have social workers who are able to go into the community and identify persons with disability. And then, so within that, they also have rehabilitation programs, for example. So if they find someone with disability who's quite young, they're able to take them through. But also if they're older as well, they're able to receive services out of that. We're slowly starting to bring out material in terms of how to, slowly diagnose or how to know the difference. Because again, as Mama Margaret said as well, there's people with Down syndrome. That one is kind of more visible. There's people with, we have young people with epilepsy that are also our athletes. And that can sometimes be a bit difficult because unless maybe they have a fit or they have, a seizure or something, you wouldn't know that they have a disability. We have one athlete specifically who I will tell her story maybe a bit later. So you cannot tell that she has a disability. So sometimes people don't believe her. But there's social workers who work with this. For now, we have children, so they work with the children until they're grown. We have one athlete who's like 24 years old now, so the workers have been working with her for this long. And then, so pretty much people would go to the center and the center would help them out. But then also we are trying to find ways to be able to push in more effort to have health workers in the community, but also just people who specialize in being able to offer care and help within the communities, and that can also ease the job in regards to the social workers who, sometimes it becomes a bit difficult.
Yeah, wow. Thank you so much for all that. I think it's something quite interesting. And as you said, many of us have been confusing Paralympics with Special Olympics. So it's nice to know that those two are different. And it's also important for those who are in Juba, if you're in the community and perhaps you know someone in the community who may have a challenge or impairment, please refer them to go to Usratuna, because that is the starting point from where they can access many services. Okay, next we're going to go to Mr. Kriel. Please unmute yourself. Mr. Kriel, thank you for joining us. You are a social worker, a licensed master social worker, and you work with special needs groups, which include people with disability. You're also a behavioral specialist. Please share with us your experiences of working with special needs groups and tell us some of the types and causes of challenges in the groups that you work with and how you identify or diagnose the individuals with these challenges. Welcome.
Thank you, everyone. As Dr. Grace has said, I work with mental illness patients and people with disability. So physical disability or intellectual disability affects many, individuals. So we treat those people the same way we'll treat the regular people. So the difference is that because they have a disability doesn't make them different. And so we treat them under the category of mental illness. They come to us. I work in the hospital. But what makes it complex for them is now they have the physical or intellectual disability on top of the mental illness. And maybe mental illness came as a secondary to having the physical or intellectual disability. So we address the whole mental health of a person, which include our emotional, psychological, and social well-being, and it affects how we interact with people, how we relate with people, and how we function day to day. So our lives are affected by that. Now you factor in a blind person or a deaf person or someone in a wheelchair, or in children, the most common one was one Ms. Grace said, autism, which majority of our kids that we work with are artistic, they're in that spectrum of autism. So we treat them how we would just treat the regular people without disability. The difference now is we modify programs or modify things for them to fit their needs. I can hear you, Doctor.
So you've told us about some of the groups that you work with. How do you identify or diagnose some of these individuals? Do you particularly do that, or do they come to you already with a diagnosis?
When they come to the hospital with mental illness, I do the diagnosis. Me and my colleagues, as a behavioral health specialist and as a master's level, I have been trained to diagnose patients. So I'll give them the diagnosis, either they have bipolar, depression, anxiety, autism, and all that. And then then I make the recommendation and the psychiatrist take over when it comes to the medication management, but I do the diagnosis of those disorders.
Okay. So what are the most common mental health problems among people with these challenges? Is there a particular set of mental health problems that you find too common? Maybe depression or substance abuse or bipolar, as you've mentioned. What is really common among these groups?
I think each demographic is different depending with which area, but I think the most common one is depression. Depression comes in different form and as stresses, situational stresses. Either you don't have a job, employment opportunities are difficult, which is with people with disabilities that are already discriminated. So how getting a job or job opportunities are hard for them. Social isolation, they're isolated by the the society, or because of the stigma they're having. So depression is the most common one that they have, but I've seen patients who have bipolar, and they have the disability. I've seen schizophrenia. For the kids, it's their autism or the spectrum that they have. Anxiety is another common one. So depression and anxiety are the most common one that I have seen.
Okay. Yeah. Thank you so much, Mrs. Tokrel, for your perspectives on that. Next, we're going to go to Dr. Lydia. Please unmute yourself. So, Dr. Lydia, you are an audiologist. I am sure there are so many people who are so curious to know who is an audiologist. This might perhaps be the first time they are hearing the word audiologist. So please tell us, who is an audiologist? What do you do? What inspired you to pick this career? And maybe there is a South Sudanese girl or young woman out there who perhaps would want to be an audiologist. Please tell us briefly what audiology is and what it entails.
Okay, thank you, Dr. Grace. So an audiologist on the broad scope is a professional who's trained to assess, to diagnose, and then also to treat or manage hearing and balance disorders. Me as a pediatric audiologist, and specifically at the hospital and clinic networks that I work in, we only deal with hearing. So as a pediatric audiologist, you're trained to diagnose hearing loss in children as young as newborns, and we work with kids up to 21 years of age. So you may wonder how we even test a newborn. They're not going to raise their hand when they hear sound. So the way we do it is we do quick screenings shortly after birth. If they're full term and healthy and they're about to be discharged to go home, we do screenings where we check the health of the cochlea, which is the organ of hearing. And then we also check and see how well the auditory nerve is taking sound up to their brain. And so if they fail, they get a rescreen. If they fail again, then they come to our clinics to get a full assessment. And in that full assessment, we're doing a comprehensive test to check. We check the outer, middle, and inner ear, because at times, a lot of children fail because maybe there's some mesenchymal fluid from the birthing process, and that fluid hasn't cleared. So of course, sound will not get through that. If they truly fail because of something deeper, typically what we call a sensorineural hearing loss, or maybe the auditory nerve is not taking sound up to the brain very well, then we see them again to confirm the diagnosis before we proceed with talking about a hearing aid.
Yeah. Sorry, Dr. Lydia. I think there is a lot of echo in the background wherever you are. I don't know if you have another page that is opened up streaming this. There's a lot of echo while you're talking. So maybe you can check if there's another tab that is open with this same show running. Maybe you can close it because it's very difficult to hear you. Okay. Sorry to cut you short. Yeah, but you can continue.
I've turned the volume down. Has that helped at all?
Yes.
Okay, that's what it was. So yes. What else did you catch?
That's it. Now we can hear you clearly. Yeah.
Okay, so do you want me to start from? I'm not sure what all was caught.
No, just briefly. You can just. I think we were able to pick you, but just briefly, you can go back.
Okay. All right. So again, the broad scope is as audiologists, we're trained to assess, diagnose, and to treat or manage hearing and balance disorders. And the hospital I work at, the hospital and clinic networks I work at, we specifically deal with hearing, and we test newborns shortly after birth, or we screen. If they pass the screening, then they go home. If they fail the screening, we rescreen. And that's for babies who are born full term and healthy. Then there's the other population of children who are born prematurely. So there's a high risk of hearing loss depending on how long they are admitted into the ICU, just because there's certain medications that are toxic to their hearing. And so we track them a little closer. Also, they're at risk of acquiring some sort of infection. For example, like cytomegalovirus, which depending on when they contracted the virus, it also puts them at risk of hearing loss. So you may be wondering how we assess newborns, because they're not able to raise their hands and to let us know when they hear. So we use objective measures to check the hearing structures. So from the outer middle ear to the inner ear, and then how well the auditory nerve is transmitting sound to the brain. And based on those measures, we can see if it's abnormal, and we need to follow them up closely. There's actually a committee called the Joint Commission on Infant Hearing, and they roll out protocols for how closely we should follow children based on what their case history is. So for example, if they acquired meningitis, they're at high risk of hearing loss, so we follow them closely. And then if they show to have a hearing loss, then we're aggressive about getting them hearing aids to treat that if possible. And if it progresses to the severity of deafness, then we consider cochlear implants.
Okay. So I'm just curious,
yes.
because you're based in the US, do you screen all babies who have been born for hearing problems? Is that a routine?
That's a very good question. So it used to not be the case that universal newborn hearing screening was implemented in all the US, but now there's a 98% rate of newborns who are born who get screened. And that's really important because just from congenital issues, we catch about 2 out of 1,000 babies that are diagnosed with hearing loss. So that's not counting ones who acquire it from a virus, or who have other complications. That's not counting ones who also have a comorbid condition. So some of you mentioned earlier some syndromes. There are syndromes that are associated with hearing loss. For instance, Down syndrome. There's Turner syndrome. There are renal syndromes. So because sometimes when there are issues with the kidneys, there are issues with hearing because of common structures in development.
Yeah, thank you so much for bringing that up, because later we would like you to tell us now why it is important to pick up hearing loss early. So briefly, just tell us what it takes to be an audiologist. You may inspire a South Sudanese out there to become an audiologist.
Okay, what it takes. So obviously you have to get your high school diploma. Once you get that, then you get a bachelor's degree. It doesn't have to be in communication disorders or communication sciences. You could start out, as I did, on a different track. Initially, I thought I'd be an accountant. So I was in the business track, and I finished with a degree actually in finance. But then I didn't find that fulfilling. I knew I needed to be in healthcare, helping people. But then also I'm kind of a coward when it comes to bodily fluids and blood. So you can actually take courses that puts you on track to applying for graduate school. And then once you apply, you have 4 years to complete your doctoral degree. So you can do a clinical track where you deal with patients, or you can do a PhD track, or both if you really love education that much.
Okay, thank you so much for that. So could you give us examples of hearing loss, causes of hearing loss that you come across in your practice and that you think may be relevant even in the South Sudan setting? You've talked about infections. You've talked like cytomegalovirus infection. I know that is hardly ever diagnosed because in our setting in South Sudan, because we don't have the testing capabilities for that. But you've also talked about the syndromic diseases like Down syndrome or Turner syndrome. So definitely for health workers back home, if they see such cases, then these children need to be sent or referred for hearing assessment. So are there other causes of hearing loss and not necessarily in the pediatric age group?
Good question. So I'll start with pediatrics because there's ear infections are so common, and depending on how chronic ear infections are, it does cause hearing loss. It can cause hearing loss, and if it's not treated, it can cause long-term hearing loss. Typically, hearing loss from ear infections are temporary, and depending on how frequent it occurs, it can be treated by ear, nose, and throat special doctors who are otolaryngologists. They put tubes in and drain the fluid out and just manage and track and make sure that that resolves the problem. Also, there's also genetic hearing loss, which our screening does a good job of catching. Like I said, it's 2 to every 1,000 babies that are born with hearing loss. And then also there's trauma. So any head injury at the hospitals that I've been at, we've had kids with gunshot wounds. We've had kids who have had injuries or motor vehicle accidents, so car accidents where it compromises their temporal bone, which then compromises the structures in the ear. There's also tumors that can grow along the auditory nerve that could impact hearing, and certain medications. So I believe it's quinine, depending on the dosage, could cause hearing loss. And then there's certain antibiotics, so aminoglycoside antibiotics. And then we see patients who are on chemo for cancer treatment. We track their hearing loss over time because we see a pattern. They start to lose their high frequency hearing loss. And that way it gives the doctor, the oncologist who's treating them, the option to maybe dial down the dosage of maybe the cisplatin or carboplatin, so that, because nowadays people survive cancer treatment more so than back then. So then you're looking at quality of life. And so to help with that, they try to reduce the risk of hearing loss from that.
Yeah, thank you so much for mentioning that. And I'd like to just point it out to our listeners. For example, in our setting in Juba, as he has mentioned, ear infections in children should just not be left unattended. You need to take the child to the doctor, and the child needs to receive ear drops, because if it is left untreated, that can result to hearing loss. Infections like, for example, meningitis you mentioned can also cause hearing loss. Now, drugs, you mentioned drugs, and one of the very common ones is quinine, as you have said, which is used for treatment of malaria. Quinine treatment for malaria can even cause hearing loss if the doses are too much. So that is something to look out for. If someone is on treatment for malaria and they complain about hearing, then they need to be assessed for hearing loss. Thank you so much for that. Unfortunately, I can see that Margaret has dropped out, but we will still continue. And I'd like to talk about life for people who have challenges. Okay, Mr. Creel, there is a question for you from the audience, and the question is: there are differences between physical and mental disabilities, and how do you advise the community to be sensitive? So you can have some time to think about that. Since Ms. Margaret is on,
What
the
was the
question
question again,
is,
Dr. Grace?
what are the differences between physical and mental disabilities, and how do you advise the community to be sensitive? So that is a question from the audience. But we'll give you time to think on that and respond to that. We will have Mrs. Margaret, who can now respond to the previous question that we had raised. How does someone deal with the stress of caring for someone with a disability? Please go ahead, Ms. Margaret. And while you do so, please also tell us how life is different for people and families with learning challenges. What are some of these challenges that they face? Welcome, Mrs. Margaret.
Okay, I didn't get your second bit of your question, but let me start with the stress. Then you can ask me that other bit again. Yeah. Stress, as I think our sister there, Manuel, yeah, said, is one of the biggest causes of illnesses, imaginary illnesses. And I think that as African mothers, the stress on us are even more, especially if you get, first of all, even getting a healthy, bouncing baby girl, people will tell you, oh, we want a boy. You know, that alone will stress an African mother. Imagine now having a severely mentally challenged or a severely physically challenged child. For a start, the clan will tell you, and this I know from the children I have had, because most of the mothers I have are either single or they have actually been, like Tengad. Yeah, they say Tengad. Once you get a child like this, nobody wants to associate with you. So the stress is so high that first of all, you gave birth to a child who cannot be from our clan, because in our clan, we don't have children like that. Even when you can see they have disabilities in the clan. So the stress is so high on us African mothers that you have to admit that you need help. And usually I think the first help that comes handy, especially if your husband and in your in-laws and so on are indifferent, is your own mother, or usually the grandmother of this child, because almost half the group that I have were actually taken care of by their grandmothers. And so as a mother, you need that relief to have somebody who is older, who is caring, who is able to support you. So that is one. Secondly, if you really have access to any medical facility, it's important that you go there and insist. And I say insist because usually they'll look at you and say, what's your problem? We have so many other children who are okay, who are ill. Why are you bothering us with a child like this? So you must insist. You have to stand for the rights of your child, insist for a diagnosis. If nobody tells you what the problem is, you keep telling them that, yes, I know there's a problem with my child. So even if you don't get a diagnosis, you can still push for any help, any other help that you can get. If it's a physical, for instance, cerebral palsy, if your kid is drooling or can sit properly and so on, there will be a medical professional somewhere, a physiotherapist, an occupational therapist, or even a speech therapist, that if you insist, and I must stress this point, the mothers, the children that have got help are from mothers who refused to give up. And actually, one of the definitions of autism, they say it doesn't come with a manual. It comes with a mother like me who refused to give up. I did the same with Ruth. In England, they misdiagnosed. They said she must be having a hearing problem because anyway, she was very young. Then we came to Kenya, and the first thing one doctor gave me was a very long word, which I don't know whether I still remember. It was something like hypersterility with I don't know a degree of some disorder. You doctors, you are listening to me. Please do not tell your Southern Sudanese sisters or mothers these big words. Try and explain it in a way that they can accept, and that doesn't add to the stress, because I tell you that word alone, and I can go to a dictionary, I can Google and so on. Still, it really distressed me. Now, imagine telling a mother from the camp or from Juba or Maridi a big word, which they will just go back home and say, yeah, you are right. I am really a miserable woman who can give birth to a healthy child. So try and push for a diagnosis. If there is no diagnosis, push for any help that anybody can give you with your child. And then definitely, if you see that you're cracking up, and I told you at the beginning, I was always crying and I could never talk about Ruth, like just relate my story even to a doctor without crying. So that doesn't help. So I think at that stage, you need to try and get help, first of all, in stopping to cry and actually going to get help. So you need yourself, personally yourself, to get stronger and to get counseling if you need to get counseling. You heard from our two colleagues how important it is to go for counseling. But what I found the most helpful with myself, I had to just as I always say, take the bull by the horn. I am a trained chemist. Chemistry is my profession, but I just had to drop it because I couldn't get help. I could see Ruth was being left out. So I dropped chemistry went back to school to, as I say, take the bull by the horn. But I found out that as I took a 2-year course in South Africa, and actually it was through that course that I got my healing somewhat, because I didn't know, but I was slowly getting empowered to go back to what I told you was my breakthrough. What can I do? Basically, you have to try and get to that point where you are no longer so stressed that you are crying all the time. And usually the stress is also especially from the marriage. I was blessed with a man who fully embraced Ruth and said he was very busy, but he said, anything you need, I will even leave the other children, but divert anything for Ruth. So I had that support. It's not the case. In most marriages, it is the biggest cause of marriage breaking. So that is another stress which the mothers usually get. And if a marriage is killing you and also killing your child, I started by saying, don't go to your husband if it's that type, go to your mom or go to your mother-in-law or go to an auntie or anybody in the family that can support you, because you need it to stay strong for the child. The other thing, of course, which I've already told you, is to get empowered yourself. I was lucky enough to just drop my career and go and start a new one. And then secondly, I took the bull by the horn. I started the school. So that covered Ruth, that covered my pain. And then now it's also helping many other mothers. So stress, I think it's a killer. And we are getting it now from all of us. So you can imagine now mother in the camps in Southern Sudan or in Uganda or in Kenya, who on top of that has a severely cerebral palsy child or an autistic child that needs 24 hours care. Where do you go? Those ones is where now our sister based in Juba, who is the one with the Special Olympic Lamb, please, these are the ones you really need to look out for, because they need relief. They need immediate relief from this child so that they have space to be themselves and in a secure way where they know that my child is safe. Then I can go and take a breather, either work or take care of my own family or even my own self. So they will need somebody trusted or a facility that is good enough to relieve them from just the daily care of these children. And usually you'll find their stress starts to reduce. But what I find most effective is to join a group. Clubs are easy in the West. You people in the US and so on, there's almost a club for every other thing, even for just being short or being too tall or being too fat or something. But for us in Africa, we need serious groups that can address the stresses that the women face. We are starting slowly now. I think you all know Kiswahili, the word, vikoba, these groups where women at all levels are coming together to start putting together even elfu moja, mia tano, and they're building themselves. So that is a money one, an economic one, but they need a mental, psychological, emotional support groups. And again, our sister on the ground, Lam, if you can identify these women and get them together and let themselves be the ones that relieve each other from the care of their own kids, a bit like a daycare group. I find that is the most trusted, because that other mother won't have my kid because she also has a child like that. So this, I think the group therapy, the thought that I'm not alone, I'm not the only one on many issues. I'm not the only one kicked out of my marriage. I'm not the only one that's done a sin to this clan or whatever, just a support group, but specifically for mothers who have these children. And then, of course, you cannot get away with the fact that we need facilities, which is there for every other children, the so-called normal ones. Why aren't there facilities for disabled children, especially mentally challenged ones? The ones that very easily the community will say are kicha, And you know, Kicha here is a curse, you know, literally mad, you know. And how can a 4-year-old child, 3-year-old child, 6, 8, 9, 10 be labeled Kicha, mad? No, it's usually because they've seen running around in the community or outside their homes, instead of in a facility, a proper classroom, a proper school, a proper clinic, or a proper, even a village outdoor something, which is official, which is recognized. It can be run by these mothers themselves, but the authorities and officials should not get away with the fact that they need to provide services for these children. And I tell you, as a mother, if you know that from 8 in the morning up to 3 o'clock, which is like when we run the school, my child is safe with Margaret. My child is safe with the teachers, the good teachers of that school. You know, I can go to the market and sell my vegetables, or I can run quickly, go and visit my mom, or, you know, go to hospital myself or something. So I think we'll start from the top. So you ladies who are connected with our mothers, our sisters, or those in authority, do not let them get away with ignoring this group and saying, we have issues with those who are normal. Why should we bother about this one? They need to provide proper schools, proper facilities, proper clinics, and professionals assigned to them who can help. And then, of course, counseling services for. So stress, I don't know, the one who asked this question, she needs to first admit that you need help. However strong you are, you will never be able to be happy with disability or with somebody who is challenged, who is not doing well, who is not reaching their proper potential. And where you are being blamed as the mother, as the one who sinned, or, you know, the bad one, God is punishing you. Or, you know, like here they like to say, once you drive a car or you have a big house, you sold your child, you know, to get money. These are all very stressful things. Even if you personally, you are not having it, it will affect you once you know it's happening in the community. So accept help and look for it and insist for getting the help for yourself and for the child.
Yeah, thank you
And
so
your
much.
second question, I didn't quite get.
Yeah, so thank you so much for pointing out the challenges, some of the challenges, stress being one of them, and the stigma being one of them. You mentioned the support group. I think in Juba it's called the round. There are like, okay, in Kenya they're called chamas, and I think in Juba it's called rabata. I think Nadak, you can correct me if I'm wrong. It's a round table where women come together to contribute money and they just come to socialize. So as you've said, that's a good avenue for them to come and care for others who may be having the same challenges. So you've talked about those challenges. I'd like to go to Ms. Maya, who will talk to us briefly about some of the challenges that they face in South Sudan, briefly, challenges and successes, and then we will still come back again to you, Margaret. Yeah.
Okay, so since we have been working for a short period of time, but also we have great insights from our social workers who are at Usratuna and also are with us. So one of the things actually was, which is an experience that I'd like to share, is we usually have games, right? So we had the Special Olympics World Games 2019. It happened in the United Arab Emirates. And it was our first year running, but the organizers were like, you should come and then try it out so that also you could have some experience and some knowledge. The next time you can come and officially participate. So we went and we had a team that went and the kids did amazing. Our athletes got around 4 to 5 medals between silver and bronze and a few ribbons that they brought home. And it was really interesting because also the parents were surprised. I remember even in our meeting with Vice President, His Excellency Taban Dengai, who was the first Vice President back then, they were saying that we were even shocked that our kids could do that. And that's also because nobody talks to them, nobody tells them what disability is, how to be, vigilant for that, how to care for the children for that. And then, of course, stigma, which is something we will talk about later, is just like, as they say in Arabic or regular Arabic, they're like, Nasil awirin. And it's just like, why do you want to label the, poor children for no reason whatsoever? They have great talents. They just have to be harnessed. So that was a really good, important experience for the parents to begin with, let alone the entire community and the entire public. So they were able to now slowly get to understand the experience that the children have. Challenges, first of all, again, awareness is an issue. Advocacy, we're realizing that we have to kind of start from the bottom, telling people what disability is, and then we have to go tell them what intellectual disability is and how they can help. Services infrastructure is completely terrible in terms of hospitals and clinics, especially those that can cater to their specific needs. And I'm so glad to meet Dr. Lydia, because also the audio aspect of it is really important, especially to us, because they also have to go through testing frequently. So that is the hearing, their eyes, their bones, limb, to also make sure that they're fit for exercise. So we also have a shortage of doctors who can cater for that. Actually, our official doctor for Special Olympics is a psychiatrist. And there's also very few of them in the country. And also in our discussions with Usratuna, we also realized that they also have an issue with doctors, but also primary healthcare centers. The main hospital is Juba Teaching Hospital, and then you have other smaller private clinics, but also the small clinics within the neighborhoods and just outside of the neighborhoods, they don't have the necessary expertise that is needed for them to be able to cater for people with disability. So it's either they go to the main hospital or they find a specific doctor who works with them, who can be able to care for them, which is a big challenge, because if something happens or they fall, or for example, or at least with epilepsy, if they have a fit, for example, the person wouldn't know what to do or how to help them. And that, of course, if it is left for a prolonged period of time, it can have permanent and more like long-term effects on their overall health. So that has definitely been a challenge. Support has been also a bit of an issue, because again, there are people who don't understand what it is, so they may not be so open to come and support us or listen to what it is that we have to say as to how to explain it. Whether it is government funding is kind of not there, and private is also just a bit of a hustle in regards to that. So awareness and training, a lot of training is needed within the communities, within the centers. Hopefully we can build more centers. We need infrastructure, even schools. These young people don't have schools for themselves. I've also interned with an organization that Inclusive Education in Terekeka County, Central Equatorial State. And they also had their challenges, because they also have teachers who have not been experienced or been taught as to how to deal with their children with intellectual disabilities. So there are several challenges. On a national level, there's no adequate laws that can help in promotion. So it's definitely on a individual level or on an organizational level, which sometimes does not get very far. And it has to be continuous, which again, sometimes people do prioritize other things more than do issues of disability, which is actually quite unfortunate. But I'm glad that as groups, people are learning to push more. And also we're trying to find innovative ways as to how we can bring in also groups like student leaders, young leaders in their primary, secondary schools, to be able also to carry out the awareness and the advocacy in regards to that.
Okay, thank you so much for that, Ms. Nyadak. Dr. Lydia, please, could you tell us how hearing loss affects quality of life?
Okay, so if a child is not able to hear, that impacts their speech and language development. So if you can imagine, If they're not able to express themselves, that can cause behavioral issues. But there's frustration in that, and that's why I want to touch on what Margaret mentioned earlier about why your daughter was misdiagnosed as having hearing loss. We do see lots of children who walk into the clinic, and because depending on where they are in the spectrum, they are not responding to sound stimuli. So I see why there's that misconception. But going back to hearing loss, that then impacts how well they do academically. And if they fall behind their peers, which they will, even with a mild hearing loss, because hearing loss is not a light switch. It's not on off where either you hear everything normally or you're deaf. There's degrees to hearing loss. So yeah, research supports that with mild hearing loss or unilateral, so one-sided hearing loss, children still fall behind. And so if they're not able to develop academically with their peers, then they fall behind, which then limits where they can be as far as the career path that they can choose for themselves. And then, of course, I think Tokriel can touch on this, but then that impacts their self-esteem and their, their social skills. So that's why we want to catch hearing loss early. And our goal as pediatric audiologists is the audibility of soft sound, because there's certain speech sounds like the S, SH sounds that are really soft sounds, but they convey meaning in speech and language. And so all this to say that it can really negatively impact their trajectory.
Thank you so much for that. So your take-home message is that we need to catch hearing loss early because it can affect what they can become in life, because their academic performance and what their life opportunities will be. So Mr. Creel, we'll go back to you. Please unmute yourself and answer the question on how the community can be sensitive towards people with physical and mental disabilities. And if you have anything to add about challenges or successes in these groups, briefly. Thank you.
Thank you. I think the question was the differences. Physical disabilities are medical conditions that impairs the person's ability to perform or live independently, to do day-to-day tasks. And those are mobility, hearing, speech, vision, or cognitive abilities. And they are the obvious one. You can see a person in a wheelchair, or you can see a blind person. Now the mental disability or the mental illnesses are the disorders, the mental disorders that affect us internally, and you can't see them. You can never see or know somebody has depression, and unless you screen them or diagnose them, or anxiety. Some will show physical abilities of those, but you have to be diagnosed. I think there's a lot of stigmas with mental illness altogether, leave alone when you factor in disability. So we need to be very sensitive with our population, both mental illnesses and people with disabilities. Imagine if that person was your family member, or it was you in their position, how would you want to be treated? I always use the golden rule: be treated how you would want to be treated, or treat others how you would want to be treated. So if you have that mentality of, excuse me, sorry about that, children. So if you have that, you use that mentality or that criteria, you want to be treated the way other people see you or the way they treat you, then it's better. So we need to be sensitive to that area, that these are our brothers, our sisters, our mothers, our children. And so let's treat them with that sensitivity. And Dr. Lydia had mentioned self-esteem is affected when it comes to that. Already they're isolating that, depressed, they have the mental issues, and then now the physical disability gets in. So they've already become an outcast of the community. Being an outcast of the community, that affects their self-esteem, how you socialize, how you interact. So we have to build that self-esteem. And those are the many of the challenges that people with disabilities experiences. On top of it, it's like they have not only double diagnosis now, they have the physical, the mental, and then if they have substance abuse, then it becomes triple diagnosis of what they have. And that even just of itself, dealing with all those kinds of disorders all in one person, it can take a toll on somebody. People can end up taking their own life or attempt to take their own life, which is a common thing that a lot of people have done, or they have in the field that I've worked with. That's the first question when I meet a person, do you have thoughts of wanting to hurt yourself? And it's a common thing, but for the community, we need to education, especially South Sudan. And I think that's what drove me into mental health field is when I came to United States almost 20 years ago actually. And to know that mental illness is not because your neighbors bewitched you or it was a witchcraft or it is a disorder and it's a mental, it needs to be treated, is how I ended up going into the field. So education is the biggest, educating the community, letting them know that that's not, it's not a disease. It's like cancer or any other medical issue.
Yes. Yeah.
So that's the biggest thing is education.
Yeah. Thank you so much for that. Yeah. So the next phase of our discussion, briefly, we will talk about, I think, Mrs. Margaret, you needed to talk to us about some of the successes that you've had with the people you've worked with. If you can keep it brief, give us, for example, one success story that you have had with the people you work with. What support services are required, what support services you offer, and what your outcomes have been. Briefly. Thanks. And unmute yourself.
Oh, okay. As a parent, I said, I realized that if we are really to be helpful, if we need help, we need long-term help. So our program is set up so that we receive the children young, but we keep them until they have gone through all our program. We start basically with just basic therapy, and then we do life skills training. We do functional literacy, just to learn how to read and write. But most important, we teach them job skills so that by the time these kids are about 10, 15, 16, they actually can take care of themselves. And then from around that time, we start to give them job training. And we have all the skills that you can imagine that everybody takes for granted. They take care of goats, they take care of chicken, and we have a fish pond, we have vegetables. And so very soon, these kids actually learn all these skills. And then when they get to 18, we actually employ them. And so now we have 10 of them who are employed by the school in each of these income generating projects. And the biggest outcome is that they are able to take some money home, to their families or communities that had written them off. And then we've been able to reverse this stigma that says they are a burden, they are useless, and their self-esteem come out so much, they have the confidence. One young Maasai boy actually asked me to look for him a girl from the town to marry. He he thinks he doesn't deserve a girl from the village anymore. So really my biggest joy as a parent is to see that a child comes extremely helpless, confused, labeled as mad and all this, and we are able to place them back into their families and into their communities with job skills. So what we are planning now is that the 10 who are our pioneers will be set back into their homes and in their families with a business. And I know that same guy who asked me to get him a girl to marry is our specialist in the goat project. He can deliver goats, he can feed them, he knows when they're sick. So why not? We are planning now to set him up with 10 goats and maybe 20 chicken back with his single mother, his widowed mother. So this is really the biggest outcome, that parents, first of all, get relief. They stop worrying about what will happen to my child when they are 20 and so on. We take care of that. Our program is long-term. And we start with basic therapy, whatever they need, speech or physiotherapy. Occupational therapy is the best. reflexology, all those that they need when they're young. And then, of course, life skills training and jobs is really the thing we all need now, because in Africa, South Sudan, young people are loitering around with degrees without jobs. And has a twist, ours who are mentally challenged are actually having jobs now. And the village is saying, oh, wait a minute, what's happening at step by step? So that's, I think, the biggest success we have, that we take care of them. It's around holistic program into adulthood. And they'll stay with us as long as they need to stay. Yeah, so I think that's really...
Yeah, thank you for that. I think that's a great model of what a center like that can do or can be. And hopefully we can have something like that in South Sudan. Yeah, if you ever think about it, think of bringing such a model back to South Sudan. Lydia, Dr. Lydia, please, could you tell us what some treatments are available, what some of the treatments available for, what type of treatment is available for hearing loss, and how people with hearing loss should be supported? Briefly, thanks.
Okay, so I've mentioned a bit of this before, but like with ear infections, and they see, the ear, nose, and throat professional, doctor who can manage or actually treat the hearing loss with tubes. And then with, for example, there's cases where there's sudden hearing loss, which I think is scary for most people, because you can wake up one day and then your hearing's gone on one side. So depending on how fast you get in to be seen by a doctor, they can use steroids. They can inject steroids through the eardrum into the inner ear to try to recover some of that hearing back. That happens with like infections, like an autoimmune infection. If the hearing loss is permanent, depending on the severity of the hearing loss, you have options of hearing aids, or if, assuming that the cochlea is in good health, cochlear implants if the person has severe to profound hearing loss. So with hearing aids, we see children routinely to check and program the hearing aids to make sure the hearing is not changing. There are certain conditions where the hearing can change for the worse, like enlarged vestibular aqueduct. It's a structural issue where if they hit their head, the hearing loss gets worse. So we have to make sure the hearing aid is programmed to where the hearing loss is for that.
Okay, thank you for that. We are about to conclude our discussion today. So Ms. Nyadak and Mr. Creel, please give us your concluding remarks. We'll start with you, Ms. Nyadak, and then Mr. Creel.
I think it's definitely really important, and I'm glad that people are catching up to realizing that disability really is not an ability, and that there actually is mechanisms that can be taken, to make sure things happen. Osratuna is doing a really good job, and hopefully in the future I can highlight them a bit more, but we need more, structures and more centers rather than just having one for like the total population of the entire country. At Special Olympics, we're really working hard to ensure that we're able to reach the states. We're able to acquire data that will be better reflective of the numbers that we have, but also be able to provide, support for people with intellectual disability, and also as we join with other groups of people with disability. Other than that, I would really like to emphasize, especially our compatriots and our fellow people in the Legislative Assembly, working with the ministries, with the cabinet. It's about time that we need to pass a law. It's about time that we need to have more support, even if it is restructuring the budget to at least cater for these really important sectors, health, education, because these are all really some of the major issues that people with disabilities go through, because they're not able to access services that can be able to ease their lives. So that is really important, and I look forward to hopefully speaking with also my fellow panelists in the future to see how we can, better the situation in the country. Thank you.
Thank you for that. Mr. Creel, please give us your concluding remarks.
What I would say is, mental illness or disabilities you could function and live a normal life if you're given the chance. So let's give these individuals chances. Let them realize their full potential and let them be productive members of our society, because they're able to live better if they're given the chances. Let's not punish them. Let's see them as, value them with respect, treat them with respect and value them, because at the end of the day, they said that the citizen of our country and we need them, because we all need each other in that country. Let's listen to them, listen to their fears, listen to their hopes, listen to their needs, and let's provide the best we could. Education is one of the biggest thing. Educating as one of the challenges. Let's try to educate each other and just live to get, seek the help you need. And for the family members who are caring for these individuals, as Ms. Margaret has said, it's not weak to ask for help, because I have worked with kids with autistics, and they're one of the difficult cases to work with. So parents get burned out easily. And in United States, they have respites or um, centers where the kids go for a couple hours to give parents a break, because at the end of, if parents don't get the break, they may end up abusing these children or doing, so they get those chances. So as a society, and what I wish for South Sudan is to have a society that can acknowledge mental illness and treat the individual with mental illness and physical disabilities as a citizen that need respect, and that they're functioning, and let's give them a second chance in life to function.
Yeah, thank you so much for that. Mrs. Margaret, we would like your concluding remarks. And also, I'm just curious to know, and maybe other people may be wondering, we all have hopes, dreams, and ambitions. And I'm sure for those of us who are not having any form of disability, we all perhaps hope one day to get married and have children. How does that look like for people with disabilities and perhaps people with learning challenges? Please, if you can shed some light on that and talk about anything else that you may not have touched briefly as we conclude. Thank you. Unmute yourself.
Yeah, sorry, I had to change my position. My phone was running out of charge. Yeah, with respect to the ordinary rights of every human being that we, the so-called able-bodied, take for granted, for people facing challenges, it's not per se that they will not be having need for these rights. And I think what is coming from this session, the most important is that the people facing challenges need those rights. In fact, we need to fight for them even more. The basic rights that the UN has spelled out, many countries have, alluded to it, the basic right to shelter, to housing, to food, to care, the moral rights, which I really see as an obligation of every human being to accord respect. Respect is one of the important things in acceptance. And once you accept somebody, I think those of you who are married, I think all of us in the panel are married. Once you accept this guy and you fall in love with him, you won't even know that one toe is sticking out badly. Or it's later in marriage you realize that, oh, you mean this guy is, what we find out after marriage. Once you accept somebody, whether they're blind or deaf, or they're struggling with some paralysis or whatever, once you accept them, you're already positive. So that means everything, it will change your mindset, the way you look at them. And so when an issue like marriage comes, it won't be an issue. I've seen so many special needs people, deaf people, blind people, or Down syndrome, for instance, or even people with mental illness like bipolar and all this, who with medication and with support and understanding have got married and they've raised normal children and who then later even help them. People with albinism, for instance, it's not automatic that their kids will also be albinos. No, they've given birth to children who are okay. So it when we start like having qualms about them getting married, it means we ourselves are not yet accepting them. We are not really loving them the way we love everybody else. We are definitely not being kind to them, because why wouldn't a boy who is raging with hormones not think about getting married and so on? I mean, this young man who asked me to get him a girl from the town because he figured out he doesn't, deserve a village girl anymore. That was a big eye opening to me. So, of course, I had to take him to the social class and start discussing all those issues. By the way, we have a social class for them, discussing issues of marriage and sex and, abuse and dealing with strangers. And in that class, he was helped to figure out that no, you can't just marry when you don't have anything. You need to get a job, so you need to work hard here, and so on and so on. So, to cut the story short, we need to change our mindset, our thinking about these people. And I believe that with proper support from the families, from the communities, from the government, from the institutions where they are, most of these people should be able to experience what we, the rest of us, take for granted. There are cases, of course, like severe cases of autism, where they themselves, as individuals, need really very close care and watching. And I think Tekrel as well, some of the patients you have, they may have desires to have girlfriends and boyfriends and marry and so on. But as a guardian or a caretaker or a professional, you have to caution them, because if they can't take responsibility for themselves, it means it will be very difficult for them to take responsibility for a spouse and definitely children. So what I'm saying is that we shouldn't just lump that all disabled people should not get married. No, that is discrimination, and that is a negative mindset. They should have a right, first of all, to get to their full potential with support. You've listed already, Islam and Takrel and Doctor. We've all spelled out what these people need, what this population needs. So our responsibility is to make sure they get to their full potential. Enjoy sport like Miss Lam is really trying. Let them enjoy that. Why not? Let them have clean facilities, proper facilities. And then issues like marriage should not really be a big issue, as long as they get the support and the acceptance, the love, the kindness, the patience which we are called to each other. One very important thing we have at school is a child protection policy. And I think that everybody should be encouraged to develop their own protection policies for children and also for adults with special needs, that the whole community around them are aware of these policies, especially regards to protection and abuse, that everybody signs, that they understand these things, and they will. Otherwise, I think one of us mentioned earlier, they are very, very prone to neglect and abuse, and especially sexual abuse. The girls will be abused and nobody will know because they can't speak. So I think that one thing that we should all stress and help communities to develop are protection policies for these people, besides all the positive things that we do for them. And I don't really now have anything different that the panelists have already said. Maybe what I would like to stress is that care for this population must start from the top. We should not let our leaders get away with neglecting these people, not apportioning a proper budget for them, and not urging all the facilities not to discriminate, but to include these people. And I always say that if this population is included right from the start of any institution, starting policies being developed and so on, from the top, from the government, up to the grassroots level, there should be no need for a special panel like this because they would already have been included. Inclusion is the thing at all levels. We have no excuse for excluding anybody who is having challenges. And
Yeah.
let me just add that earlier on when I talked with Grace, I told her that using the word disability is misleading. We have chosen to use challenges because you look at me like this, I look so normal, but I have so many challenges. And even our doctors, we are afraid of you guys. We think you are so learned and so on. But if we were to be honest, you might be challenged,
Yeah.
maybe with, I don't know what, history. I mean,
Mhm.
some of
Mhm.
you, find it hard. So, I mean, personally, if I keep telling people, if they took you to Russia, for instance, now, yeah,
Mhm.
you will be instantly disabled language wise if you don't speak Russian. Yeah,
Mhm.
but Russian language, that's a challenge. These days we even have apps and so on. You just need somebody to say, hey, old lady, turn on this app and you might. So I just want to say that let's also be careful when we use the word disability. We all know now it's not inability. It is
Mhm.
just being different and being abled in a different way. And let's just include these people, let them be part of us. I had also told Grace that inclusion is so important because if God intended these people to be by themselves, disability would be in only one island, maybe Zanzibar or Lindi or New Zealand or something. But you doctors know that in every population, 1 out of 10 is having some challenge. But now I even told you all of us are having challenges. So everybody
Mhm.
has a challenge or another. So let's not think of them as different or separate or out there. No, let's think of them as we make our policies, as we draw our budgets, especially budgets. We give money to whatever things that don't need money so much, and we leave out education, which is the basic, the foundation for all our children. And then, of course, one word I want us to use, and I think who is the legal person here, is positive discrimination. I think
Mhm.
in this case, I will allow it, although I'm pushing that everybody should be treated equal, including special needs people. I think that in Southern Sudan and in Africa, we need positive discrimination. If money is not enough, I will push, and Miss Lam, you can recruit me, that
Mhm.
money should be given to the to the challenge, to the Special Olympic Fund. If there's not enough health facilities for a school, Ms. Lam, you say we will start with the blind children and the deaf children and the ones with the autism or whatever. So I think at this stage, because we are so behind in Africa, and more so, with our challenges in South Sudan, we need to fight for them so that they can be put to the front line. Because really, to be fair, if I can't see very well, I can't hear very well, if I'm having trouble figuring out what's going on because I have mental challenges, I should be helped first, shouldn't I? That's
Yeah.
positive discrimination. And and I think that we should push for this. And
Sorry, unfortunately, we have dropped her, but she has been dropping a lot of wisdom, and we've learned so much, and especially what she has left us with positive discrimination. That is something that we always need to think about as we are dealing with special needs groups. Dr. Lydia, any closing remarks briefly?
Well, I think Margaret made some really good points. The only thing I would add to that is just that no matter how slight or um, I would say, yeah, no matter how slight the disability or the challenge is, what we're pushing for is equity. Like what Margaret was saying, it's not that equality, because equality means we all get the same care. equity meaning that I give you the support so you need to get me on your level. So that's all I have to say.
Yeah. Thank you. Mrs. Margaret, if you have 1 minute perhaps, if you didn't finish what you were saying, and then we will close up. You're muted.
Include, and positively discriminate for the level where we are.
Thank you. All right. Thank you so much, everybody. Thank you for being with us. We have come to the end of our discussion. And please feel free to comment. Please feel free to share this video. Please feel free to like, and let us continue to raise awareness about issues to do with people who have any form of challenge. And as Ms. Margaret has said, we all have challenges, and we must push for positive discrimination for people with more challenges than us and inclusion of these people. Thank you all and have a great weekend. Bye.
Thank you. Bye-bye.
Bye.